Good morning to you all, and I'm coming again live again. My first video was for the strategy for the UPSC combined medical service preparation, and today I will be discussing some question regarding the most frequently question which is asked in the 2000 in last 2000 to 2015-16, and it will be a very small video, and it is a type of part 2 video. So, and the basic purpose of making this video is to make you prepare that to appear in the exam and do well in the your exam, which is the upcoming exam in the 25th of March. Now, I will be discussing in paper 1 and paper 2 both. And firstly, I will be discussing in paper 1, and then I will be discussing paper 2. Now, paper 1, the most common question which is asked, every question is very common, but some question which I have marked as a common question which was asked frequently in last 10 years. Now, I will be asking, I will be giving you assertion statement, and then I will be telling you the reason for that particular statement. Now, the question is that it is an assertion statement, and the question is preferred thromboembolic regimen for the treatment of PT or pulmonary embolism is 100 mg of TPA, which is administered as a continuous peripheral intravenous infusion over 2 hours. And the reason they have given for that assertion statement, which I told you, is patient appeared to respond to thrombolysis up to 7 days after pulmonary embolism has occurred. Now I will give you 10 seconds. You think it that what will be the true, A true, B true, or both A, B true, or false, both false, one true, one false. I will give you 10 seconds, and then I will be discussing you the answer with explanation. Okay, now I will be giving you the answer. The assertion which has been given, it is true, because the preferred thrombolytic regimen is 100 mg of recombinant tissue TPA, which is administered as a continuous peripheral infusion over 2 hours. It is given, and after that the patient appeared to respond to fibrinolysis up to 14 days after the pulmonary embolism has occurred. So the assertion which has been given as a statement here, it is true, but the reason for that assertion, that patient appeared to respond to thrombolysis up to 7 days after the pulmonary thrombolism has occurred, that is false. Why it is false? Because you should understand that now some of the pathophysiology of the pulmonary embolism are that why pulmonary embolism occurs. Embolism occurs because due to the difference between alveolar and arterial gradient. So the common gas exchange in pulmonary embolism are hypoxemia and increased alveolar arterial O2 gradient, and when that abnormality occurs, then there is a the PVR or peripheral vascular resistance increases, and there is a chance of pulmonary embolism. Other than that, the main important point which you should know is impaired gas exchange due to increased dead space. Dead space is, or naturally it will increase. So and as such alveolar ventilation will increase. Then there is a increased airway resistance, due to which the ventilation will be increased, and decreased pulmonary compliance. Massive thrombus may cause also right heart side failure. You should also remember. Now, what are the most common symptoms? Now, you should know that in pulmonary thromboembolism, what are the most common cause? The most common cause is, first of all, most common which is seen when we were in the emergency or when we were in the hospital, and most commonly it comes from thromboembolism, is dyspnea, and tachypnea is also there. Then these are the two are the most common sign. Other than that, you can get syncope, hypotension, etc. But the syncope has clinically, if you get syncope and hypotension or cyanosis, so it will be a massive thromboembolism. Now, if there is a pleuritic pain, and if there is a cough or pinkish cough or something like that, so it may suggest small embolism, but we should also exclude the pulmonary edema, acute pulmonary edema. Now, when pulmonary embolism occurs, concomitantly. Now, when it occurs as a secondary or it occurs as a primarily with CHF or pneumonia, clinical improvement often fails to despite standard medical treatment, whatever we do. So with DVT, the most common symptoms is cramp. Now, when there is already DVT has been set in, so you will be developing cramps and in the lower half cup, and pulmonary infarction usually indicates a small PV. Now, what are the ECG changes? ECG changes are very important to know that the ECG changes are sinus tachycardia, which you will get in all the leads, precordial, cordial, in chest, okay. And new onset of, there also can be new onset of AF, okay, or flutter, where it is a S1, Q3, T3 sign, which we say. That means S wave in lead 1, Q wave in the lead 2, and inverted T waves in lead 3. Okay, that means precordial leads, not frontal leads, not chest leads. And QRS axis, if you will see, it will be greater than 90. Now, the basic the lab procedures, which are the lab test which we do, is D-dimer. So D-dimer will be naturally, it will be increased, and in DVT it is generally 80%, but standard which we do in our pulmonary embolism is more than 95% accurate. Now, if you do imaging, if you do a chest X-ray, you can see a central pulmonary artery local oligemia, which you can see in the chest X-ray, which is also known as the Westmark sign. And ventilation perfusion, the ventilation perfusion equation is low, and CT with IV contrast is the preferred test to do. And the pulmonary embolism rule out the criteria for pulmonary, like the laboratory findings are the, if there is a arterial gas, if you do like ABG, which we almost do, it will reveals acute respiratory acid. Here the respiratory acidosis comes into play, and the reduction of arterial PCO2 that allows the embolism in the most discriminating finding, because hypoxemia is present in the several disorders. So now what you should also know that what the differential diagnosis of DVT. Now, sudden severe cough discomfort, now it may be a rupture of Baker's cyst or something like that. Fever, chills usually suggest cellulitis, like if that symptoms come, so you have to do the differential. And massive DVT presents with already thigh swelling, tenderness, erythema, etc. Now, here the assertion which has been given that preferred thrombolytic regimen for the treatment of pulmonary embolism is 100 mg of TPA. That is very true. And patient appeared to respond to thrombolysis up to 7 days after pulmonary embolism has occurred. So here we do not do thrombolysis as such, because here the standard treatment regimen, as I told, that is done, and the patient usually responds if the patient is acutely controlled. So the reason statement is false. Now I am coming quickly to another question. Now again I am coming to the assertion and reason question only, and here the assertion is that when I will be giving, I will be telling you for 1 to 2 minutes. I will keep quiet, and you think and you make your answer, and then I will tell you the answer. Now, assertion statement here in this question is for the treatment of acute episode of severe asthma. For treatment of episode of severe asthma, inhalation is the preferred route for induction bronchodilation. Okay, and intravenous administration of bronchodilator offers no exchange over inhaled route. Okay, now this is the assertion statement, and after the assertion, the reason for that particular assertion has been given as the rare question which I have told. So you think for that. Again, I am repeating the question. For treatment of an episode of severe asthma, inhalation is the preferred route for inducing bronchodilation, and the reason for this is intravenous administration of bronchodilator offers no advantage over the inhaled route. Now, in this question, if you have just logically, if you think, then the assertion and the reason both are correct, and here the reason which has been given is the correct explanation for that assertion. Why? Because you can see the short-acting inhaled beta-adrenergic agonists are effective during excavations. Okay, so short-acting we give SABA. Short-acting means SABA, short-acting beta-2 agonist. So during excavation, and beta-adrenergic agonists are used in all patients to treat the acute symptom, because in acute LABAs are of no use. So we give to treat acute use, and inhaled beta-adrenergic agonist therapy is as effective as oral and parenteral therapy in relaxing the airway smooth muscle and having advantage of rapid onset of action and fewer side effect. So this concept you must know, that what is the difference between SABAs and LABAs, and where SABAs are used, where LABAs are used. So IV and SC route are reserved for the patients who are unable to take the inhalation due to extremes of age or due to mechanical factor. Like mechanical factor means if the patient is like ventilated or something like that. So IV route is IV and SC route as preferred. And here as the assertion question are given that the treatment of episode of severe asthma, inhalation we give. So preferred route and bronchodilation, and intravenous administration of bronchodilator offers no advantage over inhaled routes. Because if you give intravenous and if you inhale, so there is no advantages, because patient will respond accordingly. So there is no extra advantage if you give directly intravenous administration. So this is the correct explanation for that particular assertion. Now I'm coming to another question which are asked, because in your forthcoming exam, this is the most common which will be asked in this assertion or this type. Now this question is also very important, which I want to share with you. Question is, which one of the following does not cause small vessel vasculitis? Now you think it, and then I will be discussing with you. Now, which one of the following does not cause small vessel vasculitis? Now that is, first is CSS or Churg-Strauss syndrome. In option B, HSP or Henne's colon purpura. C is Kawasaki disease, and D is microscopic polyangiitis. So you think for a while, and after 10 seconds I will be giving you the answer with explanation. Now, I think you have thought your answer. So the answer for this question will be Kawasaki disease, because Kawasaki disease does not cause small vessel vasculitis, because Kawasaki disease it causes it causes greater vessel vasculitis. So now before proceeding further, you should understand that because if you classify the primary vasculitis according to their predominant blood vessel involved, the large vessel vasculitis, or I said the giant, the great cell vasculitis are this Takayusu arteritis, then giant cell arteritis, which is also known as temporal arteritis, Behçet's disease, and but one of the main important point you should know that the Behçet's disease also may cause small, medium, or large side blood vessels also. So, and medium vessel vasculitis are like, say, MPA, microscopic polyangiitis, or polyarteritis nodosa, Kawasaki disease. So this causes medium. And small cell vasculitis like ANCA-induced disorder like Wagner's granulomatosis, Churg-Strauss syndrome, drug-induced vasculitis where antihistone will be high, etc. So now the basic point of telling me this difference is that you should understand that what are the predominantly small vessel attacking vasculitis, what are middle vessels attacking, and what are very small attacking. So here Kawasaki disease attacks the large vessel vasculitis, and it causes large vessel vasculitis. Now if you go into the more detail here, actually in the large vasculitis, what will you see? What are the symptoms actually? So the clinical manifestations of the large vasculitis, as the case here is the answer of Kawasaki disease. Now Kawasaki disease actually does not cause small cell vasculitis, it causes large cell vasculitis. So in the large cell vasculitis, what the symptoms you can get is the limb claudication. Asymmetric blood pressure you will get. Asymmetric blood pressure means in the limb you will get a separate blood pressure, in the lower limb you will get a separate blood pressure, and you will be getting absence of pulses. Brutes you will get out, and if you do a echo or if you do a simple transesophageal echocardiography, you can get or MRI also, if you do, you will get a aortic dilatation. So this is the typical manifestation of large vasculitis. Now, in the case of the medium, in the medium cell vasculitis, you will get cutaneous nodules, ulcers, digital gangrene, very much common. Digital gangrene is very much common in the microscopic polyangiitis, which is medium vessels vasculitis. And livedo reticulosis is also there, and there is multi-neuritis multiplex also there, and microaneurysm. This is the very important thing which you should understand, that what are the clinical manifestation in the case of the large, in the case of the medium, and in the case of the small. Now, in the case of the small vessel vasculitis, now like the Churg-Strauss syndrome and ANCA-induced anything like IgA vasculitis, HSP, etc. Here you will get first of all purpura and vesicobulous lesions. Urticaria you will get. You can get geographism also. Glomerulonephritis is most common there. Alveolar hemorrhage, cutaneous extravascular necrotizing granulomatous, uveitis, episcleritis, and scleritis. So these things are more common in the small cell vasculitis. So I think you have understood. Now let us move to the next question in paper. Now I am discussing the paper 1 only. So I will be discussing paper 1 only. Now this is also a very important question which is occasionally asked, but in other form or the other. The question is very simple and the answer is also very simple. The following types of cancer and the following types of CAs rather commonly metastasize to the CNS except. Now you have to tell the wrong answer. Okay, which of the cancer metastasize to CNS? Which of the following CA does not metastasize to CNS? And the cancer is ovarian CA, breast CA, melanoma, or acute lymphoblastic lymphoma. So you just think and I will be telling you the answer. Now I think you are ready with the answer. The answer will be all the option which I have read: ovarian CA, breast CA, melanoma. All these metastasize to the CNA, and among these three, which I as a medical oncologist have encountered, particularly this breast CA are more like to cause the lesion in the secondary metastasis in the brain. But nevertheless, ovarian and melanoma also causes. Only the one metastasis, only the one cancer which does not metastasize to the CNS is ALL. So ALL is actually a hematological malignancy. It is not a solid organ malignancy. And in brain, whatever I told, I am just explaining you. In the metastatic is more common than primary brain tumor. And like brain metastasis arise from the hematogenous spread, and the lung actually is the most common origin of the brain metastasis. So, but CNS lesion is also seen, and here there can be a as per the explanation, confusion between choice A and D. Although ovarian carcinoma rarely metastasizes to brain, but acute lymphoblastic does not metastasize, as I told you. But I have seen the patient on the ovarian CA, particular histology, which I am not remembering right now. It metastasizes to the brain. So, though it is not common, but it metastasizes. Ovarian CA, particularly I think it is a non-germ cell tumors. It metastasize to the brain. So you have to remember this. These are very easy questions and you should remember. Now I am coming to Another question is a very important question. Now, you should this question is also very important. It is also asked in some way or other. Which of the following is not considered as a first rank symptom of schizophrenia? Now, it is very important. First rank symptoms, second rank symptoms. You should have a thorough understanding of the schizophrenia, its types, its symptoms, and its differentials. Now, here, which one is not considered first rank symptom? First rank symptoms options are auditory hallucination, then insertion of thought, then C, delusional perception, and D is the compulsive act that relieves the tension. Now, here are the four options you think, and then I will be giving you the answer with mild explanation. Now, I think you have made up of your answer. Now, the following, which is not considered as a first rank symptoms, is the option D. Okay, compulsive act that relieves the tension, because all the option which I have told you, like auditory hallucination, delusional perception, or insertion of thought, all are under the first rank symptoms. Other than that, what are the first rank symptoms is the audible thoughts, voice hearing, arguing, voice commenting on one's action, or thought withdrawal phenomenon, very common, like thought insertion or differentiation of broadcasting, something like that. Passivity, made impulse, made violation act, somatic passivity, then delusional perception. But compulsive act that relieve tension, it does not occur. Okay, in schizophrenia, this type of act does not occur. Rest occurs, and they are also known as the first rank symptoms of schizophrenia. Now, next question which I will be discussing is the which one of the following anti-epileptic? Now, I will be discussing about the which one of the following anti-epileptic drugs can be used as a mood stabilizing. Now, you have to thoroughly understand what are the mood stabilizer drugs. Okay, on that basis only the question has been formed. Now, which one of the following anti-epileptic drugs can be used as a mood stabilizing drug? First is phenobarbital, option A. Option B, phenytoin. C, sodium valproate. D, lamotrigine. So, you just think for 5 seconds. I will be giving you the answer after that. Now, I think you have made up your answer. Now, here just you have to critically think, because phenobarbital, phenytoin, lamotrigine, etc. We just acutely we don't give. Actually, particularly phenobarbital we don't give. Phenytoin also we don't give. Lamotrigine can be used somewhere as a mood stabilizing, but it is not indicated. It is a not mood stabilizer drug. Mood stabilizer drug in this option is only sodium valproate. Other than that, lithium is also best considered when we give for the particularly for bipolar disorder, bipolar or unipolar disorder. Now, actually, the treatment for this bipolar disorder is mood stabilizer, and the lithium is the drug of choice. But here, lithium was not there, so I have marked. So the answer will be rather sodium valproate. Now, this is my particular last question, because I will be discussing paper 2 also. So the following complications, this is of paper 1 only. The following are the complication of cocaine poisoning. Now, what are the, you have to understand that what are the symptoms, or what are the symptoms which are seen in the cocaine poisoning. Now, the first is angina and MI, B is epileptic seizure, C is hypothermia, and D is hypertension. Now, you just think it for a while, then I will be giving you the answer. Now, the complication of cocaine poisoning. Now, the following are the complication of cocaine poisoning except means you have to tell the statement which is wrong, which is not the symptom in cocaine poisoning. Angina and myocardial infarction is very much seen in the cocaine poisoning. Epileptic seizure is also seen. Even hypertension is also seen to some patients. But what is not seen is hypothermia, because the patients are severely malignant hyperthermia they present with. So now you should understand that what is cocaine. Now cocaine is a stimulant and local anesthetic with potent vasoconstrictor property, okay, and it is obtained by the leaves of the like Erythrithyllum coca plant, and it increases the synaptic concentration of monoamine neurotransmitter like dopamine, norepinephrine, and serotonin. Now here the main signs and symptoms of cocaine poisoning is, first of all, as the name suggests, it gives hypertension also, and tachycardia and hyperthermia, not hypothermia. So the question was asked as a hypothermia. Other than that, agitation, muscular hyperactivity, seizure, hemorrhagic infarct, subarachnoid hemorrhage may also occur. It may also cause as ophthalmic artery ischemia, etc. Now here to reverse the particular cocaine poisoning, we actually give amyl nitrate by inhalation. There the patient can get relieved. And now I am quickly switch over to paper 2, because I think most of the question, these are these I discussed some of the question which is frequently asked sometimes. So now I'm coming to the paper 2. Now here is a very important question which is always asked in a one way or other. In paper 2 I am now discussing a case of choriocarcinoma. Choriocarcinoma, you must be knowing, choriocarcinoma is what? Choriocarcinoma is GTT, that is gestational trophoblastic disease. Now, or gestational trophoblastic tumor, GTT. So a case of choriocarcinoma, 30-year-old having one child present with the growth in the uterus in single metastasis in the lung, that is stage 3, score 4. Now you have to remember the stage and score. What would be the appropriate treatment for her? Now options, listen the options first. Single agent chemotherapy, B is multi-agent chemotherapy, C is hysterectomy with single agent chemotherapy, and D is the hysterectomy with multiple agent chemotherapy. So I'm repeating the question again, and I'm repeating the option for you again. A case of choriocarcinoma or gestational trophoblastic tumor, 30-year-old having one child presenting with the growth in uterus and single metastasis in the lung. What would be the appropriate treatment? So here you think for the answer, and I am coming to give you the answer. Now, as I told that choriocarcinoma is another name for the gestational trophoblastic disease. Now it is a spectrum of abnormal growth and proliferation of the trophoblast, and that continue even beyond the end of the pregnancy. Now GTN encompasses the persistent hydrotiform mole, that is the main thing, and choriocarcinoma is a rare entity of the placental site trophoblastic tumor. Now here we only give the single agent chemotherapy for non-metastatic GTT, and the prognosis is good, and low risk metastatic GTT also we gave a single agent chemotherapy. Now we must know that what are the initial workup to keep the prophylactic chemotherapy if the patient is of more than 40 years of age, or if the initial level of HCG is more than 1 lakh, and HCG level even fails to become normal by 7 to 9 weeks. So the main single agent chemotherapy for the non-metastatic, that is low risk or good prognosis, are treated effectively with single agent, as I told you, with methotrexate or actinomycin. Okay, and the doses are given, but the doses you have to remember, and particularly in this question you don't have to remember, because Actinomycin, actually we give 0.5 mg IV bolus with folinic acid IMBD 4 days beginning 24 hours after starting the methotrexate, etc. For day 1, day 2. Etoposide we can give 100 mg per mb square in 2000 saline over 30 minutes. So like this is the EMA CO protocol in high risk GTN. And for the single regimen low risk, we only give, as I told you, single agent chemotherapy agent like methotrexate, and to support that folinic acid is given, and it is repeated after 7 days. The cycle is repeated after 7 days. So I think you have understood this question, and now let me switch on to another question. Now, this I'm coming to the second question. Now, completing to the second question, I will be quickly discussing 2 more questions. Now, first is social physician. Question, just to listen carefully. So, social physician concept was coined, or it was mooted by whom? So, option A is Bhor Committee, B Chadha Committee, C Srivastav Committee, and D Kartar Singh Committee. So, this is the question from community medicine, and very conceptual question. This has been also asked sometime or other in a different way. But we have to understand social physician is which committee has coined this term. So now, if first before attempting this question, you should understand the Bhor Committee. Now it was the integration was preventive, curative strategies and promotional health service at all administrative level. Comprehensive health care was used, and the committee visualized the development of primary health center in two stage. And as a short-term measure, it was proposed that each primary health center in rural area should cater a population of 40,000 with a secondary health center to serve supervisory coordinating of referral institution, and long-term program with 3 million plans setting primary health unit with 75 bedded hospital for each 10,000 or 20,000 population, and secondary unit with 600 bedded. So major changes in the medical education, which include 3 months training and preventive and social medicine to prepare the social physician. So actually the main important recommendation of the Bhor Committee, which took place in 1946, was this. So major changes in the medical education, 3 months training, preventive and social medicine to prepare the social physician. And Muralidhar Committee, Chadha Committee, Mukherjee Committee, and Jangawala Committee, they all are given. But social physician, the coination of the social physician was discussed, and it was being implemented in the Bhor Committee. Now, this was rather a good question. Now, just I am discussing only the question which are very frequently asked. I am not discussing all questions because it is beyond the scope of this video to discuss all questions here. So now here see the same question which I have just asked, they have just twisted the question, and they have given which of the following committees introduced the concept of multipurpose health worker. Now as the option is Bhor Committee, Jangalwala Committee, Kartar Singh, or Muralidhar. So just in the explanation I told you that the multipurpose health worker was coined by the Kartar Singh Committee. So you can see that a single question can be it can be twisted and made up of many questions. So I think you have understood this. Now, Now, now I'm discussing the last question because it is already more than 35 minutes. Now, what is the, because in the UPSC examination they ask very simple question and very direct questions. So here also there is a very direct questions. What is the treatment of choice for desmoid tumor? First, you should understand that where the desmoid tumor occurs actually. So desmoid tumor actually occurs as rather arises from the musculoaponeurotic abdominal wall, especially below umbilicus. So there you can see the desmoid tumor, and it arises from and often seen in relation with the rectus sheath, and the recurrence rate is very high here. So, and particularly this desmoid tumor is more common in in females than males. And the trauma, muscle stretching, hematoma of the abdominal wall are the main etiological factors for the development of desmoid. And it is moderately, it is not so radio sensitive. So the main treatment of choice is wide local excision, but recurrence rate is high. So we prefer wide excision here, and because irradiation we don't do. Local excision also it can't help, because since the recurrence is very high, we do wide local excision. And local excision following radiation also we don't do, because why radiation we don't do, as I told you, because these tumors are radio sensitive. So from this today I am ending the question discussing with which UPSC paper 1, paper 2, and I will be again coming with part 3 of the session, where again I will discuss and the more and more questions. And particularly today I discussed more of paper 1 than paper 2. In the next video, when I will be giving, I will be asking you the paper 2 questions mostly, and then again subsequent paper 1 I will be discussing paper 1 individually and paper 2 individually. That will be, I think it will be better. It will be useful for you, and it will be beneficial for you. And furthermore, if you have any query, and if you have you have to ask any question which I have discussed here. Apart from that, if you have any questions related to UPSC CMS examination, you can ask, and with explanation in my in that group, in our CMS group made by Professor Dr. Rajiv sir, or you can ask me individually also. I will give you the detailed explanation. Thank you.